Hello, everyone. Welcome to our session on the best practices for the best patient outcomes across Canada. I'm Jessica from Craig's Cause Pancreatic Cancer Society, and I'm delighted to introduce our two speakers for today. With us, we have Dr. Hallet, who is an assistant professor of surgery at the University of Toronto and a surgical oncologist at the Odette Cancer Centre, Sunnybrook Health Sciences Centre, specialized in hepatobiliary, pancreatic, and upper gastrointestinal malignancies, with a clinical focus on minimally invasive and image-guided therapies, as well as neuroendocrine tumors as part of the Susan Leslie Multidisciplinary Clinic for Neuroendocrine Tumors. She completed her general surgery residency and MSc in clinical epidemiology at Université Laval in Quebec City, followed by a surgical oncology fellowship in the hepatopancreaticobiliary tract program at the University of Toronto, and additional training in advanced minimally invasive and robotic hepatopancreaticobiliary surgery at the Institut de Recherche Centre Le Cancer de l'Appareil Digestif in Strasbourg, France. As a surgeon investigator, Dr. Hallet's research focuses on health services research to examine processes, patterns of care, and outcomes of hepatopancreaticobiliary malignancies, with a focus on patient engagement and patient-reported, patient-centered outcomes. In particular, her research is supported by operating grants from the Canadian Institutes of Health Research and the Ontario Institute of Cancer Research, as well as prior early career investigator awards from the Society of Surgery of the Alimentary Tract and North American Neuroendocrine Tumor Society. Also with us today, we have Dr. Ravi Ramjeesingh, who joined the Division of Medical Oncology at Dalhousie University in May 2015 as a staff physician and associate professor. He completed his PhD in cancer research in 2004 and his Doctor of Medicine in 2008 at the University of Toronto. He then subsequently completed his internal medicine and medical oncology residencies at Queen's University before completing a clinical trials methodology fellowship at the Canadian Clinical Trials Group in Kingston, Ontario, where he also received a CAMO CIHR fellowship. His main clinical expertise is in the areas of hepatobiliary cancers, including pancreatic and hepatocellular carcinoma and breast cancer. He is currently the chair of HPV disease site group in Nova Scotia and is the director of research in the Division of Medical Oncology. His research activities and interests are in the fields of health services delivery and translational research in oncology. He has been awarded the Department of Medicine Research Excellence Award in 2017 and DOM Excellence in Medical Education Award in 2018. Pancreatic cancer is a complex malignancy, often diagnosed late and requiring a multifaceted approach to treatment and management. While the pancreatic cancer community continues its endeavors to improve overall survival, it is also critical that it prioritizes any effort that improves a patient's quality of life, which often relies on supportive care resources with a patient-centered outlook. The National Pancreas Conference provides a platform for experts from diverse sectors of the healthcare field to discuss their perspective on current best practices, which will in turn establish long-term collaborations towards an interdisciplinary approach to pancreatic cancer. This session will provide an opportunity for speakers to reflect on how the best practices in their own sector can be integrated with the best practices of other sectors, which will come together as a cohesive set of interdisciplinary best practices for optimized treatment and management of pancreatic cancer.
Yeah, I will go ahead. Thank you very much for this great introduction and for inviting me to present here on a topic that I've done a lot of research on and find very important. All right, so I'm talking about best patient outcomes in pancreas cancer and how we can achieve those, or sort of lessons learned from experience or real world data in Canada. But I think the first thing I wanted to mention is when we talk about best patient outcomes, really the best outcomes are patient dependent. We all have as physicians our ideas of we should all aim for prolonged survival, for better quality of life, or for other types of outcomes. But at the end of the day, the best outcomes might be different for each person. It might be just living longer. It might be a better quality of life. It might be having enough time to see a grandkid being born. And so what I'll be talking about is traditional outcomes that we measure, but there's many more to be taken into consideration, of course. So to get there, I just wanted to talk about sort of language first that I'll be using and discussing the difference between inequalities and inequities. So to look at how care gets to patient, those are the two concepts that I find most important. And the inequality will relate to any measured differences in health between groups. So one group has lower survival than another group. That's something that's measured, that's easy to see the difference. The inequities gets more into the interpretation of those measured differences when they are deemed unfair, unacceptable, or avoidable, and that they result from an equal distribution of power, prestige, or resources across groups of patients. And one goes with the other, but they're a little bit different from each other. And those are important concepts, even in the Canadian healthcare setting. So we tend to think that, we're lucky, we have a universally publicly funded healthcare system in Canada, and so we should be able to avoid some of disparities in healthcare because of that. The reality is, when we look at healthcare performance and the most recent Commonwealth Fund analysis, where they looked at 11 countries, including Canada, Canada actually did fairly poorly when it comes to access to care and equity. We ranked in the bottom 3 for those two aspects. So we have a lot of room to improve and to grow within our healthcare system. And why talk about health services research or access to healthcare? In my mind, it's sort of the missing link in quality of care in all sorts of fields. And so this was a seminal paper from the early 2000s that looked at how often are just like primary care interventions being done or being offered to patients. So they looked at 500 indicators or about that, including things like, are patients getting an aspirin if they have coronary artery disease? Are they getting an ACE inhibitor if they are diabetic with hypertension? And what they looked at across the United States is that in 50% of cases, patients or physicians were not adhering to recommended care. And so that's really where the gap is and where health services research can help. If we have the best treatments, but we're not getting them to patients, the patients cannot benefit from them and will have no effect from the treatments. And by, in this case, for example, increasing 50% to 70%, we would probably obtain better outcomes at a population level and for individual patients and make more gains than by inventing brand new, fancy, expensive drugs. So it's something important to be focusing on. And that's what Wold and Johnson around the same time called the break-even point, which is when medical advances become less important than the fidelity of treatment. And they quoted that the society invests currently billions of dollars in developing new drugs and technologies, but comparatively little in the fidelity of healthcare, which is improving systems to ensure the delivery of care to all patients. So are we getting the interventions we know are effective to patients so that they can benefit from it? And so how does that apply to pancreas cancer? Like, how are pancreas cancers cared for in real life? What are some of those gaps that we can work on? That's what I'll try to illustrate in the next few minutes. So first off, we all know this, for pancreas adenocarcinoma, when possible, the only curative intent management is a combination of surgery followed by adjuvant chemotherapy, and that's how we can obtain the best survival for this cancer. Unfortunately, in 80% of patients, this is not feasible, and we're dealing with non-curative management. And the cornerstone of that is systemic therapy or chemotherapy that can improve survival, but also can reduce symptoms and delay the time to clinical deterioration. So there's lots of benefits to be derived there. So are we getting those standards of care to patients in Canada and in North America, and how can we improve on it? So we'll start with surgery. So first off, this is data from the United States where they looked at stage 1 pancreas cancer. So this means like those are tumors that were like clearly amenable to resection, was possible to operate on them, and there was a hope for cure with surgery. And so the good news story, because one of my partners, Dr. Coburn, always tells me I have to start with a good news story, so that's what I'll do, is this blue line showing that the rates of resection, so having surgery for the stage 1 cancer, has increased over time and now is over 50% in the past few years. However, this also means that the rest of those patients are not getting surgeries. There's probably close to 40-45% that are still not getting surgery even in the past decade. And in 36% of cases, patients are not getting surgery and there's no identifiable reason. Meaning that in those databases, they will document whether surgery was not offered or not performed, for example, because patients were too sick, they could not tolerate the operation, or because of age, or because of patient decline. In this case, in 36%, we could not identify why that is. That's a huge gap for potentially curative intervention. And we can see it here, like those patients who get the pancreatectomy in the green and the blue line, whether with chemo or not, fare better than those who do not get it. So by not offering or not getting surgery, there's a drastic impact there. And who are the patients who do not get surgery? Well, the patients have a high risk of not receiving surgery or vulnerable groups. There are older patients, Black patients, those with lower socioeconomic status or lower education, no insurance in the United States is a concern, and those treated in community hospitals compared to academic hospitals. And in Canada, this is also true. That's data from Dan Kajadan, who's was a surgery resident, now works as a surgical oncologist, who looked at rates of pancreatectomy for pancreas adenocarcinoma in Ontario and showed that the odds of receiving surgery were lowered by 32% for patients from rural areas and by 14% for each level of socioeconomic status that you would like lower socioeconomic status. So from the highest to then like the lowest was 14% for each level. So this is massive. And, we might say, that's fine, but, surgery is not for everybody. Maybe people, like patients just don't want to have surgery, and that's fine. It's a big endeavor. It's not for everybody. It has to be aligned with wishes and values, and it's not always aligned with that. But in this case, I don't think we can explain the rate of no surgery only by patients declining surgery. And when we look at patients who decline surgery, there's also disparities here. So again, this is data from the US because we don't have this type of data available in Canada, but in those same stage 1 pancreas cancer, so those who had like clearly an indication for surgery with a potential for cure, close to 38% of patients declined surgery. That's close to 4 out of 10 patients. And thankfully this has decreased over the years, as you can see here, but it's still pretty concerning to me. And what is really concerning to me is that there's disparities in the decline of surgery. There's some vulnerable subgroups that are more likely to decline surgery. Again, older patients, Black patients, female patients, those with higher comorbidities, and then those treated in community hospitals. What this tells me is that the decision to decline surgery may not always be just informed by values and wishes, but there might be other issues at hand or bias that come from the providers as well that we can work on. And looking at the role of hospital in particular, in the US, there's about a 6-fold difference in the rate of surgery between different hospitals. This is not that high from the data I've seen in Canada, but though it's not published, but it's getting there. So it's not 6-fold, maybe about 4-fold, but there is a difference in the rate of receiving surgery across hospitals. And the hospitals who offer surgery more often and operate on more people with early stage cancer yield better survival for their patients. So like these discrepancies are important as they impact patient outcomes. And so when we look at all of this, not receiving surgery, and again, this is potential for cure or a hope for cure, is dependent on who you are, where you're from, and which hospital you get to. Those are things that we can improve on to get best patient outcomes in pancreas cancer. And then once you get surgery, the outcomes of surgery are also not the same for everybody. And that's not only based on patient characteristics at baseline. It also depends on which hospital you get to. So that's a seminal paper from the Berkmeyer group in the early 2000s that has really changed the way cancer surgery is delivered in many jurisdictions and has led to the regionalization of cancer surgery in many spaces in Canada and in Europe and some American states as well. It's certainly the case in Ontario. And so basically what we see is as the volume, so the number of pancreatectomy a hospital does per year, the mortality goes down. And the high volume was defined here as more than 16 per year. And we'll see that that's not that high in just the next slide. So in Ontario, like I mentioned, we have regionalized cancer surgery. So pancreas cancer surgery is only done in 11 centers across the province for about 14 million people in Ontario. And even within that system, when we looked at it recently, there is a difference in outcomes when hospitals do more pancreatectomy. So the first thing is just bring your attention to the fact that with regionalization, we achieve much higher volume than what the Berkmeyer paper showed. So the low volume hospital were 10 to 19 procedures per year. So even those hospitals would meet high volume criteria from the early 2000s. But then when we broke down those centers, what we see is patients operated in low volume hospital had a twofold increase in 90-day mortality after surgery. And those operated in moderate hospital had a 2.5-fold increase in mortality after surgery compared to patients who have surgery in high volume center, that is centers that do more than 40 procedures a year. So again, so another source of disparity that we can act on that is a modifiable factor potentially. And so now moving into the non-curable pancreas cancer group. This was an article that came out after we published a paper in CMAJ a little bit more than 2 years ago now about, it was right around the time where Alex Trebek announced that his cancer was being treated with chemo and was responding and he was doing better. And the question was like, well, if it can help Alex Trebek and can prolong survival, why is it so many people are not getting it? And indeed, in that paper, when we looked in Ontario at patients with advanced pancreas cancer, so those that cannot be cured with surgery and should receive chemotherapy for treatment, a third never met with a medical oncologist. So they never even had an oncology assessment or an oncology consultation. What this means is like for 1 out of 3 patients with advanced pancreas cancer, there was no opportunity for treatment. That wasn't even discussed with them by somebody who gives that treatment. And of those who did not receive treatment, so 62% in that cohort did not receive treatment, chemo or radiation therapy. Of those, 44% did not see an oncologist. So what this means is 4 out of 10 patients who did not have treatment for cancer-directed, doesn't mean they didn't get palliative care or supportive care, but didn't have like a cancer-directed treatment, there was no opportunity for treatment. The way I see this is that for those 4 out of 10 patients, there was no informed decision making. They did not have the opportunity to discuss this treatment with anybody. And what are some of the reasons for that? Well, the first thing we looked at is that in all those patients, the first person they saw in their healthcare system was a hepatobiliary surgeon, so a surgeon that does pancreas surgery. And when they see a surgeon first for a disease that is not amenable to surgery, it impacts what will happen after. And the flip side is those patients who saw a medical or radiation oncologist first, either isolated or in combination with a surgeon on the same visit, had a higher likelihood of receiving cancer-directed therapy. I think to me what this means is often surgeons are the door to the cancer system because it's easier to refer to them, it's easier to get an appointment with a surgeon, but often that delays care. That delays the assessment by the person who can really provide the care the patient needs. And so that's something we need to be cognizant of. Something else that may explain why some patients get seen and some don't is geography. So where does one live? This is work that was done by a medical student who's now a surgical resident with us at Toronto, Elliot Yee. And basically you look at adjusted rates of oncology consultation across Ontario by census division. And so the very dark purple are those that have high rates of consultation, like over close to 70%. And what we see is where there's more sort of cancer center, cancer care facilities, so mostly southern Ontario, there's higher rates of consultation with oncology. Whereas for patients who live in the northern region or regions that are located further away from the primary care facilities, like in green, the green dots, they have lower rates of consultation. And so that also translates into similar findings for who receives therapy and who does not. Now, the other thing I said at the beginning, receipt of surgery depends on where you get your surgery or, who you will see. Receipt of chemotherapy also depends on which oncology you will get to and who you're going to be assessed by. So there's volume outcome data about surgeons, and so we decided to also look at volume outcome data for oncologists just recently. So here what you see is the volume of the oncologist. So 5 is the highest volume. That was more than 16 patients a year with pancreatic cancer being treated. And the little bars here are the rate of chemotherapy across those groups. So, it went from about 38% to close to 48%, so about a 10% difference. But the most important thing to me is when we talk about variation. So the range in those groups. And you can see how big the boxes are. So in the lowest volume quintile, this means that, from about 25% to 55% of patients may get chemotherapy across that group. So there's a lot of variation, whereas in the higher volume, there is less variation. Practice is more homogeneous, so the opportunity for care is more homogeneous in those patients. And so that receipt of therapy translated in similar findings, now looking at the length of survival, how long will one survive? So same thing, there is better survival when there's higher volume, but also there is less variation in the amount of survival they get for their patients. And when we adjusted for all characteristics of patients, because we might be told, yes, but maybe the low volume people see sicker patients and fewer of them can get chemo. Well, when we adjust for all of this, high volume medical oncologists are more likely to give chemotherapy to their patient, 1.2-fold more likely to do it. And that translates into better overall survival with a hazard ratio of 0.79. And I would say any treatment or any new drug on the market that would yield that kind of a hazard ratio right now would probably get a podium at ASCO and would get into the news. And we could do the same thing by just having high volume oncologists look after pancreas cancer patients. And I'll talk about it later, but that doesn't mean we're taking care away from regional, sort of northern centers. There's ways to do it and keep the care close to patients. So what this says to me is patients who are cared for by oncologists are more familiar with pancreas cancer, so that are either subspecialized or completely specialized in pancreas cancer, have better access to therapy and longer survival. And what does this mean for the system? Well, we also looked at whether this strategy is cost effective. And it is. Actually, if a patient is cared for by a high volume medical oncologist, you're saving $1,100 per month survived per patient. Because yes, the costs for chemo and radiation therapy are higher because they get therapy more often, but then there's lower costs in inpatient care, need for home care or long-term care, which I think speaks to the benefits patients derive from the treatment. And what this showed is that this is what we call a cost dominant strategy, meaning that it's a win-win. It's better outcome and lower cost. So it's better for patients, it's better for the payer, which is the health system. So if I summarize all of this, we know there is effective therapy for pancreas cancer, and that effective therapy can improve survival, symptoms, quality of life, time to deterioration, and more. But there is a number of gaps that patient can fall through, those famous cracks. There's gaps in who gets assessed, there's gaps of who gets therapy, and that leads to gaps in the outcomes. So what can we do? So going back again to best patient outcomes are patient dependent. So, we talk a lot about standardizing care. And I don't know that standardization is really my favorite word when we talk about this topic. Because at the end of the day, we want to have homogeneous practice, standardized care, but we have to realize every patient is different. So we cannot apply the exact same principles and exact same data to everyone. So what does this mean? How can we still improve? So I wanted to just introduce, as a conclusion, the concept of unwarranted variation. So what this means is that there will always be variation in care. There's always going to be surgeons who operate on more people than others, surgeons who get better outcomes after surgery than others, or different groups of patients. And that is normal. That's just part of what it is. That's part of what real life is. But there's a part of variation that is unwarranted, meaning that is due to either underutilization of evidence-based intervention, differences in preference-sensitive care from a patient perspective, or supply-sensitive care. What does that mean? Well, the underutilization of evidence-based intervention is often ingrained into organization and coordination of care. that is how patients, for example, may not get access to a medical oncologist, or may not get access to a high volume medical oncologist, or may not get referred by their primary care provider. And that leads to unwarranted variation, whereby some groups get more chemo than others, or some groups get surgery more often than others. Second, differences in preference sensitive care typically refers to some patients would prefer treatments, others don't, and it's really a personal decision. But in reality, when we study this in more details, what people have realized is those decisions or those preferences from patients are most often influenced by the medical opinion of the provider, and how we approach this and how we counsel patients. I exaggerate, but depending on how I present things, I can sell surgery to somebody or I can convince them not to have surgery. And mostly what they have to rely on is the counseling I'm providing. So there's a lot of influence here. And in my mind, what this means is that there's opportunities for bias from providers introduced in the decision making. And then finally, the supply sensitive care is just availability of health resources. So something as simple as right now, there is a shortage of something called Abraxane in Canada. So we're not able to provide that to patients simply because it's not available. But it can also speak to other health resources, like having regional cancer centers in northern regions in Ontario, so patients can have access to oncologists on site. And so those are a few of the things that when I try to conceptualize disparities, I think play a role in pancreas cancer. Some of the most important ones to me are the stigma of pancreatic cancer, whereas lots of people, whether it's patients, families, or friends, primary care providers, oncologists, surgeons, might think that, it's a bad cancer. The treatment is worse than the disease. Why would you even bother? Just, the famous, put your affairs in order. But really, there's so much work that's been done. This is not true anymore. And even if it were true, at the very least, people deserve a conversation with the people who have the information and can help them get to care if they desire so. And so that's why, to me, the second thing is also ability to get consultations, be it with a surgeon, with a medical oncologist, with a radiation oncologist, but at least to have a discussion about care. And so everything in terms of best patient outcomes, I hope I was able to show this today. In my mind, starts with an opportunity for care. So from organization and coordination of care perspective, it means triaging consults in a way that brings people to your office. One of the things I struggle with as a surgeon is sending consultation to medical oncology, and they will not even see the patient or consider booking the patient until there's a biopsy that proves the diagnosis. And so that might delay things by weeks, and sometimes they're never able to obtain a tissue diagnosis. And that's a struggle. If it's a struggle for me, I work with them in the office next door, it's a struggle for primary care providers to get their patients to oncology treatment. Expertise or subspecialized care, it doesn't mean that we need to get all the care in, regionalized cancer center in urban settings, but it means maybe in a small team of oncologists up north that they have two that are dedicated to pancreas cancer and have a bit of an expertise in that, and they have champions for each cancer site. That's something that's feasible and still maintains care close to patients. And that speaks to high-performing teams. In terms of addressing differences in preference-sensitive care, I think we have to fight the stigma of pancreas cancer and increase awareness. Also fight implicit bias, like Dr. Noel presented yesterday in his keynote address, and have tailored support for patients. Acknowledging many older patients, Black patients, those from lower socioeconomic status, need for us to put more efforts into getting them to treatment and provide them more support. All the patients don't have the same needs. And finally, resource distribution, I alluded to about geography and having high-performing teams, even in remote areas. And so at the end of the day, what I was trying to say is, right now, we have a gap in assessment and we have a gap in who gets therapy. And what's the ideal number? What should we strive for? I don't think we're ever going to get to 100% of patients getting therapy. That's unrealistic and that's probably inappropriate. It's not for everybody. Everyone has to make their own choices. But I think what we can strive towards is having close to 100% of patients being assessed and having an opportunity for this therapy, an opportunity for the best patient outcomes as defined by them. So on this, I'll thank you very much for your attention and again for the invitation. And I will leave screen sharing to the next speaker.
Perfect. Okay, thanks everyone. Wow, it's going to be hard to follow Dr. Hallet, but I'll try to keep it interesting. So I'm going to talk about a little bit more about what we know across Canada, primarily looking at real-world evidence, because there's a lot of studies that are going on across Canada in regards to real-world evidence, which is informing practices on how to best support our patients. And Dr. Hallet has already alluded to some of it, and luckily I'm not duplicating some of the studies that she's talked about. So these are my disclosures. So the objectives is to discuss the statistics around pancreatic cancer, talk about what is real-world evidence, make sure we all have a good framework, discuss the real-world evidence coming out of Nova Scotia and the other provinces in Canada, and then open the discussion about real-world evidence to the group, because I'd like to see what people's thoughts are of things that we're missing, things we should be moving forward in this realm of real-world evidence. So let's jump into some of the statistics. We know lifetime probability of developing cancer is about 1 in 2. And this is from the Canadian Cancer Statistics that were put out about 3 weeks ago as well. So it's a high rate or high probability of developing cancer in Canada. When you start to look at the geographical distribution of new cancer cases, so on the left is the incidence rates for cancer in Canada. On the right, it's the mortality rates. The dark blue is what you would say is the higher rates of incidence, whereas the light blue are lower rates compared to others, and it's astandardized incidence rates. As you can see, the dark blue is Newfoundland, Nova Scotia, New Brunswick, and Ontario. So they have some of the highest incidence rates. If you want to go from number 1 to 4, Newfoundland, Ontario, Nova Scotia, and New Brunswick are the top 4 incidents for cancer. So there's a high rate of cancer in Atlantic Canada. Unfortunately, also, when you start looking at the mortality, which is the figure on the right, again, dark blue is the highest rates of mortality. Newfoundland, Nova Scotia, so some of the highest rates of mortality for cancer, whereas Ontario, which has highest rates, one of the highest rates for incidence, has one of the lower rates for mortality. So in Atlantic Canada, when you're looking from Nova Scotia and Newfoundland's point of view, having a higher incidence and mortality is not a good equation. When we talk about pancreatic cancer, we know the distribution projected new cancer cases. Pancreas is going to be the 10th most common cancer in men, 3.1%, and the 9th most common cancer in women, 2.7%. When we start to look at the rates in Canada that are estimated for 2021, it's estimated there'll be 6,700 cases of pancreatic cancer in Canada, distributed 3,700 men, 3,000 in women. Ontario having 2,550, Quebec 1,870, BC 870, Alberta 590, New Brunswick 160, Nova Scotia 185, Saskatchewan 175, Manitoba 210, Newfoundland 80, and PEI 30. So this is the rate that's being estimated. There are definitely cases that you're going to see. We're all experiencing them. It's not that rare of a cancer that we're seeing now as well. When you look at the cancer-specific net survival, ages 15 to 99, all stages 1 through 4, unfortunately, while you see reasonably high net survival in things such as prostate and female breast cancer, unfortunately, in the yellowish green color, this is the pancreas rate, and the 10-year net survival is only 8%. So it's pretty abysmal when you think about it for pancreas cancer compared to the other cancers as well. And this figure has been presented a number of times in the last 2 days. When you look at the projected cancer deaths by 2030, pancreas is going to be the second leading cause of cancer-related deaths behind lung cancer, with liver cancer being number 3. So this figure is taking the Canadian cancer statistics from 2017 all the way to 2021 and looking at the 5-year net survival changes over that time frame. from 1992 to 2017. And one of the things that you can see is there is a trend moving upwards in net survival. But if you're looking at the y-axis, we're only saying maximum 12%. 5-year net survival. While we are making strides in improvement, we're only talking about 1 to 3%. Not a huge amount of improvements in net survival. When we look, now this is what was published 3 weeks ago. When you look at the 5-year age standardized net survival for selected cancers for pancreas, 2015, 2017, we're seeing across Canada, on average, is about 10%, and it varies between 7 to 9%. In comparison to 2012 to 2014, where the net survival across Canada was 8%, one of the things I think I jumped up when I saw previously, we used to quote net survival in Nova Scotia as being 4%. It's now gone up to the average. So yeah, we're at the average. But we're seeing marginal improvements over time, not drastic improvements, just marginal improvements. So this is a quote from the Canadian Cancer Statistics. So although it is not one of the most commonly diagnosed cancers, pancreatic cancer is expected to be the third leading cause of cancer deaths in 2021. This is in part because the mortality rate for pancreatic cancer has stayed largely the same over the past 35 years, whereas that of the more common cancers, including lung, breast, prostate, colorectal, they've all been declining considerably. And so this is kind of somewhat of a depressing statement to hear. So now let's talk about randomized trials. So where do we get the evidence for informing practice? And the gold standard is RCTs, or randomized controlled trials. So they're traditionally recognized as the gold standard for generating clinical evidence on the treatment of efficacy and safety. RCTs offer high internal validity through highly structured trial designs. However, RCTs are very research intensive, they're time consuming, and have very stringent inclusion and exclusion criteria that really limit the generalizability of the study to the results to the rest of the world. So this is where real-world evidence and data comes into play. So real-world data is data relating to the patient's health status and or delivery of healthcare routinely collected from a variety of sources. Real-world evidence is the clinical evidence that's obtained from these sources about the usage and potential benefits or risks of the medical products derived from the analysis of this real-world data. So examples of these sources include electronic health records, medical claims, billing data, product disease registries, and patient gathering data, including wearables, apps, diaries as well. So these are all potential sources for real-world evidence or data. What's important about real-world evidence is it informs decision-making, and how it does that. It can inform decision-making when we talk about the patient, when we're talking about the burden of the disease in the population, symptom burden, disease biology, and just the routine patient's treatments, the quality of care, how treatment delivery is occurring, what is the concordance with guidelines that are available in a province in the country as well, rare cases. So randomized controlled trials are very rare to be done in rare diseases, primarily because you need a certain volume of patients to do an RCT. For a rare disease, it's really difficult to get that volume of patients. Either you have to expand this trial to multiple institutions, provinces, countries, continents to get a number of cases to do the study, or you have to make the study ongoing for a long period of time. And so it takes a long time to get that data. Real-world evidence can provide more information in a much quicker time frame. So you can get more information about rare diseases like male breast cancer, which is very rare, rare outcomes like spontaneous regression of liver cancer, or the rare patient, cancer during pregnancy. You're never going to have an RCT that's going to tell you what to do for cancer in a pregnant individual. And then, of course, access to care, looking at wait times, impaired access, referral patterns, overutilization, and then country analysis. All of this can come out of real-world evidence, which is things that you can't get from RCTs. So types of real-world trials or studies that you can get. There's the observational studies, which are non-interventional clinical studies designs that are not considered clinical trials, such as retrospective observational studies, where you identify the population and determine the exposure and treatment from historical data. Or prospective observational studies, where you identify the population of interest at the start of the study, and then you have the exposure, treatment, and outcome that you're looking at, and you collect the data from that point forward. There's the pragmatic trials, where you do clinical study designs that include elements that are very closely resembling routine clinical practice, and historical controls using data generated prior to the initiation of the study as your comparative arm. So it means you need less patients on that study because you're comparing it to generated data from sometimes retrospective studies as well. We know the rate of doing real-world evidence studies is increasing over time. So this is a very neat study from Chris Booth in Kingston, looking at the number of publications for real-world evidence over a time period, 2002, 2016, and we're seeing almost an exponential increase in the real-world data, real-world evidence or registry data that's occurring in the world. And it's primarily because clinical trials are costly, they're resource intensive, and take a long time to do. And so you can get a lot more done with real world evidence. As well, you're seeing a growth in real world evidence studies in emerging economies. When you look at this paper that was published in this year, when you look at Africa, Middle East, Latin America, Asia Pacific, there is a growth of real-world evidence studies in oncology, because again, it's things that they can do where resources may be more limited if they're looking at doing randomized control trials. So why do we need real-world evidence? Well, there are limitations when we talk about clinical trial data. So clinical trial data is highly selected cohorts or patients, is what I call the Olympic athletes. Patients are the ones that get on these studies. These patients typically have limited comorbidity conditions that are enrolled on these studies, including previous cancers. Having history of a previous malignancy will exclude you from many, many studies. There's selection bias due to barriers to access to trials. Where a patient lives, they may not live close enough to a cancer center to be on a study. There are biases for race and ethnicity getting into cancer centers as well. And then, of course, there's a bias for age. Geriatric patients typically are excluded from studies. There's usually a cutoff for how old you can be before you can get onto a study. So there's very little information when we talk about geriatric patients, and we usually are taking the data in the patient population that are sometimes under the age of 65 and extrapolating it for patients who are 70, 75, or 80 to see if it works. But we don't really have the data to support that. And then investigators, sometimes their experience with the drug may limit the ability to utilize clinical trial data. And then, of course, we don't usually have long-term toxicity data to suggest what happens with patients. So research has shown that in most randomized control trials, only 10% of the patients with cancer being studied are represented in the clinical trials. It means 90% of these patients that you're seeing in practice, the clinical trials would not have been considered a candidate for the clinical trial. So what is the applicability of that study for that patient that's sitting in front of you if they're not part of that cohort of study? So real-world evidence, the clinical trial experience may not extrapolate to patients in the community because differences in patient characteristics, variations in clinical trial use of agents, accessibility issues, and differences in toxicity. That's what it really boils down to. So where are we seeing real-world evidence coming out in Canada right now? Well, we have stuff coming out of Nova Scotia, Ontario, Saskatchewan, Alberta, and BC. Plus, there's also cross-Canada initiatives as well that is important to highlight. There's EPIC, which is Enhanced Pancreatic Cancer Profiling for Individualized Care out of BC and Ontario. And there's the Cancer Health Outcomes Research Database, which is Winston Chung in Alberta, the court study, which is looking at cross-Canada data for pancreatic cancer and outcomes as well. And so more and more studies are occurring cross-Canada and within individual provinces to see what is working and what's not working when we talk about pancreatic cancer. So let's, there you go. Let's dive into some of the data as well. And so coming from Nova Scotia, I thought let's start with Nova Scotia and then we'll probably end with Nova Scotia. So one of the earlier studies was from Dr. Molinari, who was a surgeon here when I first started 6 years ago, I guess. So this is a study looking at the variation of medical oncology utilization for pancreatic cancer patients in Nova Scotia. And so they looked between 2001 to 2011 and found about 1,160 patients that were diagnosed with pancreatic cancer. And what they did was they used radiology information. They used the Nova Scotia Cancer Registry. They did chart reviews, and they amalgamated and linked all the data together to create this population health research database that they were able to do their study. And what they found of the 1,161 patients, roughly equal between men and female, or male and female, and about 80% of them were ECOG 0 to 1, but about 20% of them had a poor performance status. Majority of these patients were in the urban, just over 50%. When you look at income, it was relatively equal amongst the 5 quintiles as well. I think what's important to note, and Dr. Hallet has also mentioned, when you look at treatment, 80% of these patients had palliative treatment, and only just over 10% actually had surgical treatment as well. So a lot of these patients were presenting where surgery wasn't really an option for them, and it was only palliative treatment that could be available to them as well. So then when you start to look at the referral patterns, remembering that a lot of these patients, 80% of them were for palliative treatment, as in their later stage disease. When you look at patients, so the light gray is medical oncology referral, the black is medical oncology consultation. So a referral has been sent to medical oncology, and medical oncology has seen the patient. 60% of the patients had a referral to medical oncology, of which only 45% actually were seen by medical oncology. Now, these are patients that had been seen by surgeons before. So when you look at patients who had not been seen by surgeons, so there's palliative surgeons, the rate of referral to medical oncology dropped greatly, and it's both the referral and also patients being seen by medical oncology. So it goes by almost half the number of patients that were seen by surgeons and referred to medical oncology. Half of them, half the rate is for patients that were palliative, which echoes what Dr. Hallet says is the surgeons are the gateway for these patients to get in to be seen by medical oncology. Because if they're not seen by surgeons, these patients were not getting to medical oncology for assessment to determine treatability. And when you look over time, while the referral slope did increase slightly, consultation slope decreased slightly, but relatively the same over time between 2002 to 2010. So pretty much linear, did not really change that much over a 10-year period. So when you start to now dive into the data to kind of say, what is the differences between patients being referred to medical oncology versus patients who are not referred to medical oncology? There were things that you started to identify. You could see that older patients were not being referred to medical oncology. Patients who had worse performance status, so maybe had too many comorbidities, or the cancer was really affecting them and making them more fatigued, tired to be seen, were not being referred to medical oncology. Patients who were from the higher income bracket were being referred to medical oncology at a greater rate, and patients who were in more of a rural area may have had a decrease in the referral patterns to medical oncology. And so the take-home messages from this was only about a third of patients with advanced pancreatic cancer were being referred to medical oncology. Consultation rates with medical oncology were on a decline between this 10-year period. And if you're located in an urban setting with a higher income bracket or had low comorbidities, you had a higher chance of being referred to medical oncology, suggesting that there's a bias for what patients were getting seen and referred to medical oncology. Now, is this applicable to today's standards? So remember, it was 2001 to 2011. Treatment has changed drastically for pancreatic cancer across Canada, including Nova Scotia. in that time frame, best supportive care and 5-FU would have been the standard treatments for pancreatic cancer for medical oncology. Since then, there's been a number of studies looking for, when we're talking about advanced disease, for pancreatic cancer. Single agent gemcitabine, which was approved in 2010 for Nova Scotia, probably 2009 for the rest of Canada. FOLFIRINOX, which was approved in 2013 in Nova Scotia, likely 2012 for the rest of Canada, because Nova Scotia tends to be a year behind in approving treatments for cancer. And then gemcitabine plus nab-paclitaxel was approved in Nova Scotia in 2015. So the study had very involved patient populations where medical oncology may not have had that many treatment options for them, but now there's much more treatment options, and it'll be interesting to see how things have changed. And we have data that I will show you later on to kind of talk about the referral patterns to medical oncology over time. So Nova Scotia is not the only place that they do real-world evidence. Alberta does some too. And so this is a study that was published in 2018, a real-world population-based study of patterns of referrals, treatments, and outcomes for advanced pancreatic cancer by Dr. Chung. And so this was a retrospective study of registry and administrative data sets. Patients were 18 years and older, stage 3 or 4 adenocarcinoma of the pancreas from 2009 to 2016, and they identified 1,600 eligible patients, 621 eligible patients. And so when you look at the distribution of the patient population, you can see it's roughly equal between men and women. You can see patients tend to be older versus patients being under the age of 20. Typically had a relatively decent performance status, though half the patients were ECOG or performance status 2 or greater, which means likely were not a candidate for treatment. Majority had no prior malignancies. 1,400 were stage 4 metastatic pancreatic cancer patients, and most of the patients passed away from pancreatic cancer. Some of the take-home messages from their study was the median time from referral to consultation with medical oncology was 16 days. 55% of patients were considered to have undergone a late evaluation. So they used a benchmark of 14 days. So patients, when the referral happened, they were hoping to be seen within 2 weeks from the referral date to be seen by medical oncology, and more than half the patients would not meet that metric. Only 50% of patients assessed by medical oncology were given anti-cancer therapy. So even if you see medical oncology, only half the time you actually received a treatment. And what they found was younger age, lower comorbidity burden predicted referral, whereas older age, higher comorbidity levels predicted non-referral. Very similar to what we see in Nova Scotia. And this seems to pan out across Canada. When you start reviewing all the data across Canada, it's the same story over and over again. The younger you are, the healthier you are, the more likely you're being referred to medical oncology. The older you are, and the more comorbidities you have, the less likely you're being referred to medical oncology. Now, when they saw this, they thought, well, we need to somehow develop a strategy to improve referral patterns in Alberta. And they developed this pancreatic cancer patient flow. And what it was to try to get patients into the cancer center, help physicians out there in the community to help with the workup and for the diagnosis, and determine where do we send the patients when we have a suspicion of pancreatic cancer. So they listed out some of the symptoms to suggest pancreatic cancer, including new diagnosis diabetes with normal BMI, painless jaundice, abdominal pain, pale, oily, floating stools, plus some of the other nonspecific symptoms as well. The workup, including imaging and lab work, ultrasound, CT scan, and then if there's a mass in the pancreas, suspicious lesions in liver or lungs, likely metastatic, they would suggest referral for gastroenterology for EUS biopsy to confirm diagnosis. If you have isolated mass in the pancreas with no evidence of metastatic disease, refer to hepatology surgeons, and no mass found in the pancreas, further workup, refer to GI. So they developed this algorithm for how to refer patients, and they're now looking at, has this algorithm improved outcomes for their patients in their province? Let's switch around to international study. So the International Cancer Benchmarking Partnership. This was an international study out of the UK, which involved Australia, Canada, with the provinces listed there, Denmark, Ireland, New Zealand, Norway, Sweden, and the United Kingdom. And the goal was to look at, in a population setting, the outcomes for not just pancreatic cancer, but other cancers as well. But I'm going to focus only on pancreatic cancer because that's the point of today. So when you look at the net survival for pancreatic cancer, and the data was from 2010 to 2014, though they collected data from 1995 to 2014, what they found was the net survival, so the 1-year net survival that's depicted here in the blue, is ranged from 21% up to 40%. It's a pretty wide variation when you're talking about the 1-year net survival. And why is there almost a doubling in some cases for survival, depending on where you are? How are things working well or not working well in places? And unfortunately, Nova Scotia was that one place that had the 21.6%. So why is Nova Scotia doing half the net survival as someplace like Australia? And then when you start to look at the 5-year overall survival changes between 1995, 1999 to 2010, 2014, what you see is there has been improvements in net survival over these timeframes, whether you're looking at Australia, many places in Canada, the UK, Ireland, Norway, Denmark. Unfortunately, Nova Scotia, there is very minimal change in net survival during this time frame, which again echoes all the data that we're seeing within our province, that there hasn't been improvement in outcomes in our province. Other provinces have done better. So why is this happening? You know, I've shown a lot of data. We're now saying what's going on here. And this schematic, I think, can hold true for any province as well when you start thinking about system issues. What are the problems? You know, could it be the nihilism that people have around pancreatic cancer? You've been diagnosed with pancreatic cancer. There's not a lot to do. We'll send you to palliative care and send you home. That has been historically the way it has been thought of in the province. You know, is there differences in treatment? You know, some places have access to treatment different than, say, Nova Scotia does. Is there a cost difference? Cost to the patient, cost to the system, cost to the cancer center? Is cost the primary cause of why we're not seeing, or we're seeing differences in survival? Is referral patterns, referral rates an issue? Is pathways an issue? And what I mean by pathways is getting into the door in the cancer center, getting in to see surgeons, seeing medical oncologists, seeing radiation oncologists. Is there a pathway issue for getting patients in? And then, of course, is there genetic differences in the Nova Scotian population, in Atlantic Canada populations, in different provinces compared to the rest of Canada? For example, with colorectal cancer, we know that there are families that have high rates of colorectal cancer in Newfoundland. Clearly, there's genetics there that is predisposing them to colorectal cancer. So the thought is there probably are families throughout Canada that have high rates of pancreatic cancer, and we don't know a lot about the genetic differences amongst these families as well. So some of the newer data that we have in our province, looking at 2014, 2017. So this is now involving some of the newer treatments for pancreatic cancer. When we look at the average age of diagnosis, it's about 71 years old, roughly equal, slightly more in men than female. When we look at smoking history, almost 60% of them have some kind of smoking history. 55% has some history of alcohol use in the past. And then when they're presenting, only about 20% of them are presenting with a good performance status when they're being seen by medical oncology, which means many of them may not have the performance status that will allow you to have treatment. And also, there's about 10% of these patients who have familial histories of pancreatic cancer as well. And it makes you wonder what is going on there. Now, when we talk about workup for pancreatic cancer, traditionally, and Dr. Hallet has already mentioned, medical oncology likes to have a piece of tissue. We want a pathological diagnosis for pancreatic cancer because in about 10% of cases that you see a lesion in the pancreas, it's not pancreatic cancer. It could be a neuroendocrine tumor, it could be lymphoma, it could be melanoma, it could be metastatic disease from elsewhere. So having a biopsy diagnosis is very important when we're talking about putting someone on systemic treatment. When we look historically, only about 50% of patients had a pathological diagnosis. And in fact, 45% of them actually had diagnosis with just imaging alone. CA19-9, which is something that we use to monitor treatment response if they have an elevated CA19-9 at the time of diagnosis, only about 2/3 of the patients actually had a CA19-9 done at the time of diagnosis. So the things that we like, imaging, biopsy, and CA19-9, it varies greatly amongst the patients. We found 2/3 of the patients were being referred to the hepatobiliary surgeons and being assessed by the hepatobiliary surgeons, and just over 50% of the patients were being seen by medical oncology. Again, this echoes the data that we're seeing across Canada. When we look at referral times, we find that if we're using 14 days as a benchmark to be seen by medical oncologists, it's very rare that we're getting patients seen within 2 weeks. You can see the bulk of the patients are being seen 14 days and longer as well. One question we've always had is there differences in survival if you live in an urban setting versus a rural setting? And when we looked at this, there's no difference. So it doesn't really matter where you are located in the province. The outcomes are similar between the two. So when we started to see this data, we said, well, how can we start to improve things? So we did a little bit of a Hpv reorganization. Traditionally, there used to be a GI group, which involved all GI cancers, and it did separate eventually into a GI luminal and GI HPV, and new site leads were created. The HPV tumor board were assigned to a different day so that the surgeons, the med-oncs, the rad-oncs, pathology, hepatology, and radiology could actually attend. It was used to be on a day that was very hard for everyone being present at the rounds. And rounds are very important to help determine treatment outcomes for patients. One of the things we did find out is Pac Insertion, so portacast insertions, which we use for IV treatment for the FOLFIRINOX for when patients go home. They have that little 5-FU pump that they need to have on. In Nova Scotia, which was traditionally being done by interventional radiology, it could take 6 to 8 weeks to get IVR to put a portacath in for a patient. Now imagine you're as a medical oncologist, you've seen a patient and it's going to take you 2 months to get them started systemic treatment because that's how long it's going to take to get a portacath or a PICC line inserted into a patient. When we saw this data, our surgeon said, no, this can't happen. And so they started implanting the portacath, and this was being done within 1 to 2 weeks now. So we were able to cut back the time for starting treatment by 4 to 6 weeks. And of course, cutting time to starting treatment by 4 to 6 weeks likely is going to have a profound effect on outcomes. We used to traditionally triage patients weekly. We would go in, review the paper referrals once a week. But of course, that adds a delay because if you go in on a Tuesday and the referral comes in on a Wednesday, you're not going to see that till the next Tuesday. So what we started to do was scanning all the referrals into PDFs, emailed, and they're now being triaged daily, which then cuts back wait times by about a week. And then we also started doing a yearly hepatobiliary multidisciplinary meeting to help assess the outcomes, the times to events, to see where we can improve things. And so what we started to see, if we look historically, is again a little more data. 2013, 2017, it was taking up to 156 days from the time of first onset of symptoms to being assessed by medical oncology. That is that's over 5 months to be from your symptoms to be assessed by medical oncology. We haven't even started about starting treatment. This is just to be assessed by medical oncology, and this is pancreatic cancer. Taking over 5 months to start treatment, it's going to affect outcomes. So reorganization occurred in 2017, and what we did see is when the reorganization occurred, we were able to cut down the timeline by 50 days, which is an improvement for our patients as well. The 2019 data showed that all of a sudden we jumped back up by 30 days, and it started to question, well, what's going on here? Why is it we made such good strides in 2018, but 2019 we took a step backwards? And it actually comes down to referrals. So in 2011, 2014, we found that referrals were about 53% for medical oncology. It went up to 62%, so about a 9% improvement in referral patterns. When we look at CA19-9 required, we saw an 18% improvement in getting the blood tests, and we saw a doubling in getting the tissue diagnosis for patients as well. We saw an improvement in patients receiving chemotherapy. 23% previously went up to 74%, so a 50% improvement in patients getting chemotherapy. We saw time to see medical oncology dropped in half. The surgeons had always done well in seeing patients in a timely fashion, but there was still a slight improvement in that as well. And of course, Pac insertions, well, FOLFIRINOX wasn't really available in this time frame, 2011, 2014, but we saw it was taking about 10 days now that the surgeons were doing this. But one of the things we found then is there was an increase in the referral patterns. More patients are being seen by medical oncology, but there wasn't actually an increase in medical oncologists to see all these new patients. And so it started to increase the wait times that we were seeing, and more patients were being treated, which again limited the number of times that we could see new consults, which is what has driven this increase in time that it's taking to see patients. So one last thing I just want to talk about. So we've talked about some real world evidence about performing practice, but the real world evidence can also describe how to treat patients. So as I mentioned, FOLFIRINOX and gemcitabine nab-paclitaxel are two treatment regimens for advanced pancreatic cancer. There's never going to be a head-to-head study to tell us which of the two is better and to inform which one we should be doing for patients. But real world evidence can actually be used to help tell us what to do. And so this was real world outcomes of FOLFIRINOX versus gemcitabine plus nab-paclitaxel in advanced pancreatic cancer. It's a population-based study as well. And so it was a retrospective study, a registry administrative data sets, patient 18 years or older, stage 3-4 adenocarcinoma from 2015 to 2017. They either had to have FOLFIRINOX or gemcitabine plus nab-paclitaxel. 1,130 patients were included in the final cohort, and the primary outcome was overall survival. And what you found was patients who were on FOLFIRINOX typically had better median survival, 9.6 months, versus gemcitabine plus nab-paclitaxel, 6.1 months, and the 1-year survival rate was higher if you're on FOLFIRINOX versus gemcitabine plus nab-paclitaxel. Now, one of the things that might convolute this a little bit is what kind of patients are being treated with nab-paclitaxel versus FOLFIRINOX. The patients who are being treated with gem-nab, for example, tended to be slightly older, tend to have more metastatic disease, tend to have worse performance status. So part of the reason we may be seeing these outcomes is because of the patient population that are getting this treatment compared to FOLFIRINOX. Partly the reason because FOLFIRINOX can be pretty toxic, and you want to have a strong enough individual that can tolerate the side effects from that treatment. When you look at the forest plot, you can see all the treatments tend to favor FOLFIRINOX versus gem-nab-paclitaxel as well. So the take-home message from this was median overall survival for metastatic pancreatic cancer was lower for FOLFIRINOX and gem-nab-paclitaxel in the real-world study. So when you look at the clinical trials, Proteus for FOLFIRINOX, their median survival was 11.1 months, but in this real-world evidence study, it was only 8.2 months. In IMPACT, which was the study for gem-nab-paclitaxel, was 8.7 months. Real-world evidence was 6.1 months. In the unresectable locally advanced pancreatic cancer, the OS was significantly greater for FOLFIRINOX compared to gem-nab, and the medians were greater for the unresectable population compared to metastatic pancreatic cancer, 5.2 months FOLFIRINOX versus 2 months for gem-nab. There was rates of hospitalization for neutropenia were significantly higher in the metastatic pancreatic cancer patients who did receive FOLFIRINOX compared to gem-nab-paclitaxel. So this evidence does provide some clues of what we potentially should be doing for our patients. But again, more evidence would be required if we're going to inform how to change things for our patients. So, summarize, the incidence of pancreatic cancer is increasing. The 5-year survival for pancreatic cancer has increased slightly in Canada, the importance of real-world evidence has increased year by year, and more institutions are relying on the real-world evidence for drug funding, treatment guidance, and to treat off that one-off patient on what to do for that patient. So the last thing I just want to pose is questions for discussion amongst the group, because there's a lot of real-world evidence that's occurring, but are there things that are being missed? What are the questions you would like answered by real-world data? What is missing from real-world evidence? And then, of course, what are the perceived barriers in doing real-world evidence at your institution? Is it resources? Is it time? And is it support? And with that, I'm going to thank everyone and open the floor to questions.